Welcome to Behavior Change Series Made Easy. My name is Beverly Thomassian. My pronouns are she, her, and hers. I'm so excited you're here today. If you're thinking about taking the CDCES or BC-ADM certification exam, this content is really great to help you prepare, feel ready, and confident walking into that exam, because both of the exams really look at the philosophy of person-centered care and the way they write the questions and approach the different vignettes and scenarios with people living with diabetes. I think this content will not only be helpful for exam preparation, but also in your clinical practice. I also like to kick it off with a land acknowledgement. We acknowledge and are mindful that Diabetes Education Services stands on lands that were originally occupied by the first people of this area, the Mechoopda. We recognize their distinctive spiritual relationship with this land, the flora, the fauna, and the waters that run through this area. Our team is amazing. We have Brianna, we have Tiffany. Tiffany is on the front lines answering your emails, your phone calls, and can help you with any navigation issues or support you on figuring out your pathway to certification. Brianna is on vacation this week. I'm so happy for her, but she's back there just really orchestrating how our website works, all the different interfaces, and make sure everything is running smooth and is really on top of our operations. I'm deeply grateful for both of these wonderful individuals. Our company, Diabetes Education Services, is an inclusive company. We are committed to promoting diversity and inclusion in our educational offerings. We recognize, respect, and include differences in ability, age, culture, ethnicity, gender identity, sexual orientation, size, and socioeconomic characteristics. Throughout our content, we weave social determinants of health, recognizing that people face many barriers to participating in diabetes self-management, and we also recognize some individuals have a lot of support. We want to share information from different lenses and different perspectives and different lived experiences so that we can take this content back to our own clinical setting and apply it to individuals that we serve. I have no conflict of interest. Where did I get all this information? Well, it's really from the standards of care, not for medication overview, but there's many. Sorry, y'all, here it is. It's standards. That little slide snuck in there. I pulled it from standard 1 and 5, and standard 1 and 5 look at population health, and then 5 is on well-being. And then there's psychosocial resources we'll be talking about. And I also pulled a lot of it from the desk reference. So the ADCS desk reference, 800 pages. And you can see there's a lot of information, a lot of chapter and content dedicated to behavior change and supporting behavior change. Here on chapter 3, theoretical and behavioral approaches to the management of self-management of health. Wow, that sounds so exciting, doesn't it? That's what I'll be really covering today. And then you can see there's other chapters that are dedicated to supporting that individual and making lifestyle changes to improve their self-management. We have somebody listening in from Canada. I just have to give a shout out to Canada since I was born in Toronto. Okay, a fellow Canadian, welcome. Yeah, and if you're having any audio issues or any technology issues, please reach out to Tiffany, info@diabetesed.net, or you can give us a call. So what are we going to talk about today? Well, I've kind of discussed it already, but I'll give you some objectives. We're going to look at a person-centered and strength-based approach. What are some common behavior change theories used in supporting diabetes self-management? And then we'll look at the components of a person-centered interview and motivational interviewing. I love this definition of diabetes care and education specialist, a compassionate teacher and expert who, as an integral member of the care team, provides collaborative, comprehensive, and person-centered care and education for people with diabetes. And this came right from the 2022 National Standards for Diabetes Self-Management Education and Support. If you are taking the exam, highly recommend you read this because it outlines the standards for providing DSME, and you need to be familiar with that. I just want to go over some words that I love. Compassionate. It doesn't say knowledgeable. It doesn't say super smart. It doesn't say expert. It says compassionate first and then expert. Integral part of the healthcare team. And then we're going to provide collaborative, person-centered, comprehensive care. Care first and education. And I think this emphasis is well put because we are compassionate, we're listening, we're empathetic, we are bringing our heart to our jobs, because certainly diabetes care is a profession of passion. We recognize social determinants of health. We recognize the importance to promote equity, and social determinants of health include education, access, and quality, economic stability, social and community context, neighborhood and your built environment, healthcare access, and quality. SDOH is an important part of providing care. As we look at that individual, we hear their story, we recognize they have barriers, and they might have SDOH that is supportive too. But to see them in their full context is a really important part of what we do. And the other thing we want to be aware of are the ADCES 7. And ADCES 7 are these 7 areas that we are going to connect with individuals living with diabetes. Do you need to know this for any future exam? I think that's a great idea. Here we have the diabetes educator, person with diabetes, and they're same level, looking at each other eye to eye. You know, one doesn't have more knowledge than the other. They both are going to bring information to the table that's going to be critical for their success in developing this collaborative plan. But look what the first ring is. It's not medication, it's healthy coping. It's not nutrition, it's not being active, it's healthy coping. Because we know if we've got the healthy coping addressed, that we can go on to the next circles. It's so hard when people are struggling with distress for them to focus on, oh, I think I'm going to eat healthier. Oh, I need to move my body more. When you're distressed, when people with diabetes are distressed, it's a real roadblock for them taking care of themselves. When we meet them with compassion and we discuss the roadblocks as around emotions and distress, we can really support them in moving to these outer layers of monitoring, reducing risk, problem solving. So yeah, be familiar with these and know that we want to help people move from dis-ease to well-being. Let's do a poll question. RT often skips breakfast in the morning so he can sleep as long as possible. Can anybody relate to that before going to work? Since they take morning insulin, this often results in hypoglycemia at work. After meeting with RT, a plan is made to have a granola bar in the car to eat on the way to work. What does this exemplify? A, problem solving, B, adult learning theory, C, trans theoretical model, or D, dash approach. And I just want to say before I launch this poll that I have 11 poll questions today. I really would like you to participate in every one. And if you don't choose the best answer, it's okay, because this is a safe learning environment and you learn just as much from choosing the wrong answer as from choosing the right answer. So I want you to trust your gut, choose what you think is the best answer. And I don't see anybody's individual response. I just see the cumulative response. Let's take 30 seconds to answer this. So they skip breakfast. He wants to sleep as long as possible. They take morning insulin and then they get hypoglycemic at work. We meet with RT and the plan is developed to have a granola bar in the car. What does this exemplify? I love the way you are choosing answers. Thank you. Okay, I'm going to close the poll because you're on fire and show your results. 96% of you chose the best answer, problem solving. I can see why 4% of you chose adult learning theory. It seems like, well, he's an adult and he figured it out. But this is not even that sophisticated. It's just like, oh, I'm getting lows because I'm not eating with my insulin. And problem solving is just working with that individual and saying, what do you think would work here? And then based on their life experience, they come up with, well, I think if I carry a granola bar, I can eat that on the way to work. simple, straightforward problem solving. So great job. Let's keep going. So when you think about problem solving, we want to reassess a treatment plan and bring barriers to light. Like we might have figured out a great collaborative plan with that person at our last visit, and then they come back and they haven't been able to achieve it. So even though we thought it was a great plan, maybe it wasn't. And usually if people aren't able to achieve the goals that we set together, that's a reflection that the goal was usually too ambitious, would be my inclination. So we want to reimagine that plan, maybe make something, a different plan. So this is important because it's not about the person failing, because they might feel like, oh my gosh, if I don't do this, I'm a failure. No, it's not that you're a failure. It's that the plan we created was not realistic, or maybe it wasn't that important to you. And I do tell people when they leave the office, if you don't do any of this stuff, it's okay. Just please come back to the appointment. I want to be here to support you and cheer you on without judgment. This is really important. So we're going to create a judgment-free zone where, gosh, I know, you're trying your best. We're going to give people benefit of the doubt. So what are some barriers? Competing demands, lack of knowledge, literacy. Maybe there was a miscommunication. Maybe they have cognition issues. They could be struggling with diabetes distress. Almost half of individuals or more living with diabetes have some degree of distress. Lack of resources. Maybe they just feel like, gosh, I don't really think those medications are working. They just don't take them because they're like, why should I take something that isn't working or that could actually harm me? And then could we consider a referral to somebody other than ourselves to support them? Social work, maybe they need some support with finances. Let's do another poll question. Which phrase represents the principles for communicating with and about people living with diabetes? A, your BMI indicates you are in the obese category. B, your fasting blood sugar is above normal. C, you should try and exercise 150 minutes a week. Or D, you are checking your blood glucose daily. Let me launch this poll. See what you'll think. Which phrase represents principles for communicating with and about people living with diabetes? So really thinking about the new language movement and lifting people up with our words. All right. Just dive in there and choose what you think is the best answer, please. Okay. All right, I'm closing the poll. Thank you, team. Share your results. So 75% of you said D, almost 20% said B, and then 6% said C. So nobody chose A. I'm so joyful about that because we don't really use that terminology anymore, saying that, you're obese. We would say a person with extra weight, person in a larger body, and, a person's weight doesn't define who they are. So we might say a person with obesity or living with extra weight, but we would not utilize this language anymore. Now let's go back. Let's go to B. 20% of you said B. So your fasting blood sugar. Okay, that seems okay. But we're trying to move away from the word sugar and use glucose, by the way. So your fasting blood glucose is above normal. Okay. So if I'm not normal, when am I? I'm abnormal. And then we're trying to move away from that word normal too, because if you say, oh, your blood sugars aren't normal, you're like, dang, what's wrong with me, right? So now I will say your blood sugars are above target or below target, or I'll use that kind of neutral language. So this is not the best approach. And then C has a should word. So that should word has a little bit of a flavor of the compliance model. You should exercise, you should eat right, you should, walk every day. When we use the word should, it's like a parent talking to a kid, and it really can undermine a person's belief in their own ability. And so what we say is we are trying to stop shoulding on people. Okay, moving on from my little joke there. And so what could we say instead of giving this person a directive? We could say, what kind of activity do you like? We don't even really try and use the word exercise anymore, because exercise means a gym, right? Lifting weights, going to a specific workout. All we're wanting to tell people right now is move, get off the couch. Number one, move your body more, try not to sit more than a half hour. And anything above that is terrific. Moving the body, especially after meals, such a big deal. So see that just changing that language from exercise to movement or activity makes it so much more achievable immediately. And that's just the amazing thing about the word, the language movement, is that our switch of word choice can make such a big difference in people's feeling about our conversation, about themselves, and about their ability to achieve it. Okay, so D is the best answer, even though it has the word sugar. It should say you are checking your blood glucose daily. It's just a statement of fact. There's no judgment involved. It's a recognition of their work, and that's why it's the best answer. And that's what I try and do when I'm working with people. Number one, thank you for showing up. Always thank people for showing up. Thank you for coming in today. And then always, the other thing is, I want to say, is recognizing the work of diabetes. I notice you're checking your blood sugar daily and you're taking your medications and you're really making a big effort to make healthy food choices. I just want to recognize that person can breathe, because they're worried about being judged. And we know that 40% of people who who don't make their appointments are not showing up, about 40%, due to feeling shamed or embarrassed or judged by healthcare providers and healthcare professionals. We want to really just open that door of acceptance and say, hey, whatever you are bringing today, it's okay. Let's just figure out what we're going to do. Here's the old way. So this is old language. We don't see if you test blood sugar. What is that? That's a pass or a fail. Somebody was just saying, yeah, instead of saying you need to move more, take an activity snack. I like that. An activity snack. Okay, getting back to this. So instead of patient, you'll notice I really don't use the word patient. I'll say person with diabetes, individual with diabetes, somebody living with diabetes. Getting away from normal blood glucose to blood glucose in target. Getting away from non-adherent. Getting away from this, like, oh, they're not adherent, they're not compliant, to just focusing on what they are accomplishing. So somebody's asking, hey, why is D the best answer? You just said, don't use the word blood sugar. It's so true. It should say blood glucose. I need to update that. But even though it says blood sugar, D is the best answer because there's no judgment involved, and it's not, using these other words that are really we're trying to stay away from. So it's the best of the answers. The thing is, what we say matters. Our body language matters. Our tone of voice matters. Our eye contact matters. It all matters. And so there's a great sheet here from the CDCES, Speaking the Language of Diabetes. How we talk to and about people with diabetes plays an important role. Conceptualization of diabetes and its management, treatment outcomes, and psychosocial well-being. Language has an impact on motivation, behaviors, and outcomes. So, this is it just happened about 8 years ago where we said, let's really think about language and the way we communicate with people. And I have a free webinar on language. You're welcome to join. It's recorded. You could listen to it, the podcast or the live version, and just get familiar with the language movement if you're not already. Okay, let's move on to learning and behavior change theories. We got this. Look at all these beautiful people with different lived experiences. We have people of different age ranges and backgrounds and, just life experiences. And this is what's so beautiful about what we get to do. We get to interact with people from across the globe, or from our local communities. But we have a lot of migration in America and a lot of people that move here to improve their life. And we get to learn so much about their experiences too. So what theory works best for you? You get to go theory shopping and see what fits you best. So you might use some of these approaches that they really resonate with you, and others you're like, oh, I don't really get that one. So whichever one feels good to you, like, yeah, I can make that happen. I encourage you to pack up in your bag and take with you, and also to be familiar with these for any future exam in the near future. So how well does it resonate? Does it extend your thinking? How useful is it to you? Maybe you like more than one. That's okay too. Let's just do this quick self-assessment. So get your fingers ready for the keyboard. LS arrives late for an appointment and says they forgot their logbook. LS has only been taking their metformin a couple of times a week and has gone back to getting fast food each morning for breakfast. What feeling would this evoke in you? So if you wouldn't mind, under the chat or question box on your screen, just typing in, what emotion does this evoke from you? And as you're typing this in, I just want to talk about one thing, that is, as healthcare professionals, we all bring our lived experience to the meeting with the person with diabetes. Like I have, I'm an immigrant from Canada, and I moved here when I was very young, and we didn't have much money when I was a kid, and my parents were very focused on certain things in my life. And I bring all of the experience. I'm talking, from my birth, but as an adult too, I have accumulated experiences. But I bring all of that to my meeting with that individual, and then they bring all of their lived experiences, which could be very different than mine. And so when we provide diabetes education, we don't really talk about this much, but the educator brings their life, the person with diabetes brings their life, and here we are, two people trying to connect in some way. And this is kind of a magical meeting. When we live and we experience this person without judgment, we can really hear what they're saying and kind of get in their shoes and see, oh yeah, I can see it from your perspective. Based on that, what do you think would work best for you? So when we look at this person, I'm gonna see what you all typed up. What feelings would this evoke? And some people said frustration, concern, unprepared, frustrated, then curious, and wanting to know how to help make things better, frustration, overwhelmed, exasperation, they're worn out with their diabetes, or maybe they don't care, curiosity, spirit of inquiry. We've talked through treatment plan, but the person's not doing it. Why? What has changed? Other. I can relate that maybe the patient is having a hard time working their health maintenance into their daily routines. Thank you all for typing this. Concerned. Right. I mean, look at, okay, this is so amazing to me. Thank you so much for sharing your feelings, because you all have different lived experiences, and look how you responded to this situation. Some of you are like, well, I'm really worried about this person. Others felt exasperated or frustrated. And so it just gives us this moment to sit with ourselves. And I know when I'm working with patients or people with diabetes, that sometimes I get feelings evoked of judgment. And I'm like, Beverly, where is that judgment coming from? And then it's not like we're bad people. We're not. We're really diligent. We're healthcare professionals. But I always think, where is this feeling coming from? And can I release it? Because once I release that feeling of judgment, I can really see the person and connect with them in a meaningful way. Yeah, somebody just put stressed. So I'm just, kind of asking us to be curious about our own feelings, and then to look at LS and be curious about them. And when I look at this person, they forgot their logbook. Okay, maybe they were flustered. They've only been taking their metformin. How come? I'm curious. Did they think the metformin is going to harm them? Did they run out of prescription? Did they not have enough money? And then they're getting fast food. Did something happen where they have some food insecurity, or they couldn't go grocery shopping, or, there's could be a million reasons. And so instead of these feelings, we want to move toward curiosity. Now, the beautiful thing about the word curiosity, somebody just typed in defeated. That's a really good, yeah, maybe this person feels defeated. Maybe we feel defeated. Here's the thing about curiosity. When we're curious, we're not responsible for that person's actions. Like, I think when we kind of are more judgy, that way we think, oh, I failed because that person wasn't able to do it. But nobody's failing here. It's just the plan isn't working. And so when we approach this with curiosity, we can figure out a moving forward together. And I really believe this will help decrease the amount of burnout healthcare professionals experience, because I think we burn out when we think we're responsible for people's behaviors. But the truth is, they're making choices, and maybe because of their social determinants of health, they're making some choices and not others. So here's just a little chart to get us fired up. So here's a judgment statement. Here's a curiosity statement. They still aren't taking their medications every day. So that's frustration from the healthcare provider, right? Like, I'm frustrated. And when we have that feeling, it closes us up. We're just like angry, or not, I don't know if the word is angry, but we're just like frustrated. Like, how come they're not doing this? And then here's curious. I wonder why they aren't able to take their medications every day. Curious is expansive. It opens us up. I can't believe they keep gaining weight. Let me explore how they are feeling about their body health. Maybe it's not even an issue to them. Maybe they feel comfortable in their weight. Maybe, they feel great. They lost 2 pounds, or maybe they've just only gained 2 pounds. We don't know. We just have to be curious. How come they can't even exercise at least once a week? Something seems to be blocking their goal to get more active. Let's find out. Why are they still eating tortillas? Well, we could change that to, how do they think tortillas affect their blood glucose levels? Can't they check their blood glucose more often? I wonder how often they think they need to check their blood glucose. It seems like we need to explore what is happening in their lives, preventing them from engaging in their diabetes self-management. These are, internal thoughts that we have, that we want to move from this one side of judgment to this other side of curiosity. And when we do, we start asking open-ended questions. And you all know the most important part of a therapeutic intervention is to ask open-ended questions, and not to give directives. So when we move from judgment to curiosity, we start asking these open-ended questions because we're really curious. And the other thing that sets up is expectancy theory. If we say to ourselves, for example, oh, they're never taking their medication, they probably never will, or like I had one provider say, well, this person's just non-compliant, they're not taking their medication every day. And then, I knew the backstory because the person had told me that, no, I'm afraid to take my medication. I think it's going to hurt my kidneys. So the provider had this one idea. And then by having this idea about the person, they set that person up to continue that same behavior. Our expectations continue behavior or can actually halt behavior. We want to let the person know we believe in them. We believe in you. I believe in you. Yes, I do. Okay, number 3, which of the following strategies are best used when someone has low literacy skills? A, speak slowly and clearly. B, underline key points on educational materials. C, direct the teaching to the support person and encourage reinforcement. D, be concrete and focus on problem solving. So a person has low literacy. Which of the following is the best strategies to use if someone has low literacy skills? Okay, I guess I have to launch the poll for you to answer. Thank you. Okay, well, are we going to speak slowly and clearly, underline key points, direct the teaching to the support person and encourage reinforcement, or D, be concrete and focus on problem solving? Thank you for your participation. Okay, I'm closing the poll and sharing your results. 16% said A, 7% B, 20% C. So 56, a little over half, said D. Okay, let's just think about this for a little while. What does low literacy mean? Does it mean that they're not intelligent? No. What does it mean? It means they didn't have the opportunity, for whatever reason, to learn how to read and write. Or they might be able to read and write a little bit, but not that much. And I work a lot with people who have low literacy because I work at Indian Health Services Clinic, and many people I work with their first language is Spanish. They haven't really acquired English yet, and they, have very low literacy skills in English, and oftentimes Spanish is really tricky for them too. Okay, but they are bright, hardworking, resourceful, resilient individuals. So low literacy does not mean that they're not capable. So let's just think about it from that perspective now. So we don't need to speak slowly and clearly. They have no learning disability. Okay, so A is not the best answer. We're not going to underline key points in educational materials. If they already have low literacy, we're probably not going to rely heavily on printed information and underlining words. Now, directing the teaching to the support person, this I would say would not be the best approach for any situation. So even when I'm, there's a translator involved, I'm going to look directly at the person who's living with diabetes that I'm providing education to, because I want them to know I see them, I hear them, I recognize them. So even if a person, has literacy issues, they can still completely understand us. But we might repeat key points. So D is the best answer. We want to be concrete, however you want to say that word, and focus on problem solving. So here's what I'm going to do. Since they can't read or write, I'm going to have to repeat key items, which I do for people who are literate, by the way, too. There's repetition involved when I work with people with diabetes, because I really want to make sure they get it, and I want them to say it back to me. In my experience, people who are not able to read and write often have very expanded capacities to memorize information because they can only keep it in their head. So we'll, utilize that knowledge and be concrete. I mean, we do this for everyone. Focus on problem solvings, and we provide information in a way that's relative and relevant for their life. So D is the best answer, and I'm really glad we did that together. Let's keep going. So we want to use the language principles that we want to emphasize what people do know, what they can do, focus on their strengths that empower them. We want to preserve a sense of dignity, direct our education to that person. We want to encourage people to take an active role in directing the day-to-day planning, monitoring, evaluation, and problem solving in their own lives. We recognize that, people have motivations to do certain things, and there might be barriers around. We want to focus on what they are achieving. And we want to explore past situations where they experienced success. And I'll say something like this, like I'll ask people, oh, do you smoke cigarettes? They go, no, I quit 20 years ago. I'm like, you quit smoking? How did you accomplish that? Well, I just decided it's time to quit. Okay. And I go, that really shows me when you decide something, you make it happen. It's so simple to do, but then they're like, yeah, I actually am really strong that way. And I do that because they're going to need to call upon that ability in the future. So what have they done in the past that demonstrates their resilience, their strength, their awesomeness? That when they wear their cape, like when are they wearing their cape in their life? We all have superpowers. We believe you can do this. That feeling that we generate to people is contagious. Okay, let's look at TR. TR is a healthcare professional getting ready to take their certification exam. They are interested in providing more person-centered care. Which of the following statements verifies they are on the right track? A, adherence to the diabetes self-care plan takes time. B, motivate individuals to engage in their self-management is the first step. See, adult learners do best when provided a step-by-step demonstration. D, create mutual agreement on the plan for the next step. Okay, so this person's a healthcare professional getting ready to take their certification exam. They want to provide more person-centered care. Which of the following statements verifies they are on the right track? All right. Okay, I see answers coming in. I'm like, okay, is everything working okay? Yes, thank you. So just trust your gut and choose an answer. It's okay. Whatever answer you choose is okay. This is a non-judgment zone. Okay, I'm closing the poll. Thank you, everyone. Sharing the results. 30% said B, 65% said D. Is D the best answer? It is. But let's just talk about B, because 30% of people chose this. So do we motivate people? Now, if you have a partner, I could ask you the same thing. I mean, can we motivate people to do something, or does it have to come from themselves? And we would say that motivation has to come from that individual. Like I could cheerlead like and jump up and down for 10 minutes telling this person, yes, you could do it, I believe in you. But it has to come from them. And so when we realize that, we go, oh, okay, I want to light the fire in them. So what gives your life meaning? What's important to you? What are you trying to work toward? We're tapping into what motivates them. So it's nuanced, but just to know, we're going to try and help them light their own fire. We're going to give them the match, but they got to find, what they're going to light. What is their internal motivation? So D is the best answer, creating mutual agreement on the plan for the next step. Yeah, we don't use the word adherence anymore. So adherence is like, oh, you need to follow this. No, we don't do that anymore. And adult learners do best when provided an opportunity to do a return demonstration. So I could demonstrate all I want. And if I could, I started this weightlifting program at the gym, and they demonstrate how to lift the weights. And I'm like, oh, okay. And he goes, okay, now do it. And he walks away. I'm like, what? I need you to coach me through this. I've never done it before. So the adult learner has to do it themselves and be given feedback. So mindfulness-based interventions, we want to avoid compliance. We want to focus on empowerment. We want to be mindful, paying attention on purpose, non-judgmental in the present, be better chance to be present to life and become less reactive to the tides of distraction. I love that. Pay attention to your thoughts and feelings too. Don't judge yourself, but explore, acknowledge, and consider. We have this great free webinar on mindfulness by the wonderful Heather that might be really helpful for you just to kind of explore some of your internal feelings. MR has had diabetes for over 35 years and tells you they know everything about diabetes, but their provider insisted they come see you to check in with their diabetes. What approach recognizes adult learning theory? A1C is 7.3. A, please share how you have been managing your diabetes. B, can I see your ambulatory glucose profile? C, please demonstrate how you use your meter. D, are you meeting your targets 80% of the time? Okay, so this is asking what recognizes adult learning theory. All right, let's see the answers coming in. I'm going to close the poll, thank you, and show your results. So 81% of you said A, 13% said C, and 6% said D. So why is A the best answer? Because this person says, I don't need to come here. I just came because my doctor made me. And then their A1C is 7.3. Is that on target? Well, we know the ADA goal is less than 7, but this person has had diabetes for 35 years. This is an accomplishment. You know, when I see this situation, I'm like, wow, this person's really doing a lot to succeed with their diabetes. And so by saying A, adult learning theory leans into that person's expertise, recognizing what they bring to the table. That's why A is so great, because it doesn't just focus on one thing. It's like, hey, how have you been managing your diabetes? So some of you chose C, demonstrating how you use your meter. Like if I said to you, well, demonstrate how you use your meter, they might feel like, oh, she doesn't believe me. She thinks I'm not capable. Like, you know, I've been doing this for 35 years. We don't want to give them that feeling that we're not trusting them. We want to really recognize their expertise. And A is really great because it's an open-ended question. C is more like, you know, show me how you're doing this. And then D is a little rough because are you meeting your targets 80% of the time? That person might feel like, well, I'm time in range 70% of the time. Isn't that, you know, good enough? And so they might feel like a little bit embarrassed if we ask that. So, you know, always, it's such a great way. If a person is coming in to see me and they're feeling a little bit, I don't know, they're not excited to be there, which it's okay. I don't take it personal. Then I'm going to ask a lot of questions about, you know, how are you doing this? I see your A1C 7.3. Tell me more about how you're achieving this. You've had diabetes for 35 years. That seems, you know, pretty amazing that you're able to get your A1C to 7.3. Now, look what I just did. I changed the relationship where they're like, oh, this person recognizes my expertise. I want to share with them and collaborate. So adult learners, just like you all, like what brought you here today? What brought you here is you probably felt a need to learn. Maybe you're taking a certification exam, or maybe behavior change theories always seem kind of, you know, foggy. Like, what do they really mean? How do I use them? Maybe you were just curious, but you felt a need to come, whether you came live or you're listening to the recorded version. And we're problem oriented. We want to know how to solve these different problems. Just don't give me a bunch of information I don't need. I want you to give me information that specifically is going to address what's causing me stress. They learn better when their own experience is used, and they want active participation. So one way I'm doing active participation with y'all is a poll questions. And that way, you're not just hearing me talk about learning theories, you're participating, you're thinking, you're, you know, using critical assessment of knowledge and applying it. And then we're having a discussion about it. That's how we learn best. So we want to support people in taking charge of their lives. And we want them to, like, for example, be comfortable using technology. I have so many people on CGMs and I say to them, oh, do you know how to look at your app and know what that means? They're like, oh, I just look at what my blood sugar is at that moment. I'm like, okay, let's look at this together. And then we look at time and range and, you know, hypo events and what is the estimate of your A1C and what's the average blood glucose. And we just look through that and they're like, wow, I can access all this. I'm like, yeah. Now that is engaging in adult learning theory where they're holding the app or going through it together and they're discovering the tools that they have. It's not about me telling them, oh, do you look at your app to find out what's on there? No, it's about them looking at it and me supporting them in that discovery process. Okay, so learning theories from art and science. What I decided to do, and this is based on the outlines for the exam and also what's in the book. I'm going to make sure and cover the learning theories that are in the book because those are probably the most important ones to know for certification exams. So we're going to launch into these and let's take a little stretch. Let's roll our shoulders back. Oh my gosh. Don't you want to be here with all this lupin and the beautiful mountains and the lake in the back? Oh, I do. Okay, poll question 6. JR is deciding whether or not to start insulin. A1C is 9.8. Mom had diabetes and severe complications due to chronic hyperglycemia. What would best describe the application of the health belief model in this situation? Health belief model. Level of readiness, more likely to start insulin if knows someone on insulin, feels empowered to inject insulin, perceived risk of future illness. Okay, so JR is deciding whether or not to start an insulin. A1C is 9.8. Mom had diabetes, severe complications due to chronic elevations of blood glucose. What best describes application of health belief model in this situation? All right, team. I'm loving your participation. Okay, trust yourself, choose something. I'm closing the poll. Thank you, everyone. Okay, so this is so interesting. 54, like half chose D, and then 15% evenly chose A, B, and C. So what is the best answer? This is health belief model. So A is a juicy answer, level of readiness. What theory, what model does that come from? Well, it comes from trans-theoretical model. So the readiness, level of readiness is trans-theoretical. We'll be going over these. More likely to start insulin if they know someone on insulin. That's social learning theory. Social learning theory is if I see somebody else doing it, I'm going to do it. Okay, so this is not health belief. Let's see what else. If they are empowered to inject insulin, that's the empowerment model. So D is the best answer, and over 50% of you chose that. Great job. Perceived risk of future illness. The health belief model looks at what is the cost versus benefit. If I start insulin, will it decrease my risk of getting complications from diabetes like my mom? So it's a cost versus benefit. It looks at the individual's perceived risk and seriousness of illness, determines the likelihood of adopting preventive behaviors. So the more the perceived risk, the more likely they are to make necessary changes. And different factors can influence this, like their level of personal vulnerability. So if my mom had complications from diabetes and my blood glucose are elevated, I'm going to feel personally vulnerable because somebody very close to my family had diabetes and they didn't, they had elevated blood glucose and complications. So I want to take insulin to prevent that. And how serious does a person believe their illness is? Are they connected to their diabetes, understanding the severity, or are they kind of not able to really accept that they have diabetes yet and they're still pushing it away? Cost or deterrence associated with making changes. So what are the costs associated with starting insulin? Well, you have to give yourself an injection. It's a hassle. You can get low blood glucose. You have to have your medication. So there is cost and there is benefit. So I just want to, that's health belief model in a nutshell, where people are just weighing the cost versus benefit of the behavior. You'll see people do this all the time. They'll be like, well, I could, but this, they're going back and forth. That's okay. We want to help them explore the cost versus the benefit. Hopefully the benefit outweighs the cost for people, but it's really their choice. So we're just going to help them work through it. Okay, social learning theory. So that person, if a person's going to like if I live in a family where everybody goes to the gym, I'm more likely to go to the gym because that's what my people are doing. And this is kind of from Bandura, one of the originators of social learning theory. And what he says is we are our connections. And if you think about diabetes prevention program or DSMES, just think of the power of that group saying, well, this person says, well, I just stopped checking my blood glucose. I'm just so burned out. And another person will say, well, I check my blood glucose on a regular basis because I really want to know if the plan is working or not. And so they're like, oh, you do? Okay, that's social learning theory. Or, oh, yeah, I go to the gym, every day or 3 days a week because I really want to build up my muscle strength to help lower my blood glucose. And the other person's like, oh, I might be able to do that. So it just, provides this opportunity for sharing what people are doing and encouraging others to do the same, just from being in the same place, a physical place, or online place, whatever they are, but the hearing from each other what's happening. And this is important because so many people with diabetes feel like they're alone out there. And once they connect with others and they hear, oh, other people feel this way too, boom, that connection can really help move them in ways that they couldn't have moved forward before. So yeah, reinforcement, self-efficacy, helping with making those changes that can be really hard. There's another theory, the theory of reasoned action. This one is least familiar to me, but let's just take a look at it. Behavior change operates through three major constructs. What is our attitude and belief toward that targeted behavior? I mean, I have one person say, I hate exercise. I don't want to move my body. So that's their attitude and belief around it. I'm not going to say, oh, activity is so good for you. I mean, it's not going to work. I want to hear their attitude and say, oh, have you ever tried anything in the past that you enjoyed? Just moving into their life view. Perception of how others in the public view this health behavior, and then extent to which the individual believes they are equipped with the knowledge, skills, and accessibility needed to perform the behavior. So attitude, perception, and their belief in their ability work together to clarify and predict the person's intention to engage in that behavior. Okay, let's do another poll question. Which of the following statements by the educator best reflects using the empowerment approach? A, we are here to help motivate you to get to your A1C to target. B, do you think if you make a concentrated effort, you can achieve an A1C less than 7%? C, what are some reasons you want to lower your A1C? D, I believe if you follow our suggestions, you will achieve your goals. Okay, let me see. Oh, 7. What best reflects the empowerment approach? All right, the votes are rolling in, so I'll wait a few seconds. Okay, I'm closing the poll. Thank you, everyone, and sharing your results. So 77% of you chose C, 13% said B, and some of you chose A. And so empowerment, what it means is we want to encourage that individual to take charge of their life. We realize that diabetes is a self-managed condition, and people are going to leave our office or the hospital and then make all those decisions on their own. We want to empower them to make decisions that really work for them. So that's why C is the best answer. What are some reasons you want to lower your A1C? We're tapping into why they are motivated to lower their A1C. So let me just look at B. Do you think if you make a concentrated effort, you can achieve an A1C less than 7%? So anytime we're talking to an individual, I want to try and use open-ended questions. And this is a yes or a no. And it's not really empowering them. It's kind of saying, well, do you think if you really work hard enough, you can get your A1C down to 7? And what if they do say no? Then what? So that's why C is better, because it's open-ended and it really pulls upon the person's wisdom. We want to move away from non-compliance. People with diabetes are asked to take an active role in directing their day-to-day planning, monitoring, and problem solving. Non-compliance denotes passive or following doctor's orders. We want to evaluate perceptions about their ability and self-efficacy. I just love empowerment model. It's so resonant. That word is overused, of course, empowerment, but it's kind of making a little bit of a resurgence. But look at this definition: helping people discover and develop their inherent capacity to be responsible for their own lives and gain mastery over their diabetes. I love this because when we empower people to be responsible for their own lives, then we're not responsible because we can't be responsible for everybody's actions, right? We're just going to support them on their journey and help them with problem solving. And this is so powerful because it takes the onus off of us and it gives that onus to the person, but they're not alone. We're here to support them. So the choices made by the individuals have the greatest impact. They're in charge of their self-management, and the consequences of their decision is affects the individual most. So this, okay, if you haven't printed out this piece of paper, if you're taking the exam, I would definitely print it out and have it available to study before you take the exam. This is traditional and this is empowerment. Let's look at a few. Diabetes is a physical illness. Pancreas isn't working right. Nope, diabetes is a bio, so yeah, there's something wrong with the pancreas. Psychosocial, so emotional, mental health, and social environment is impacting diabetes self-management illness. Wow. Um, Learning needs are usually identified by the professional. Nope, they're identified by the person with diabetes. Education is primarily didactic. Nope. Didactic, like lecturing. Patient experiences are used as learning opportunities for problem solving and serve as the core for the curriculum. Wow, this is amazing. I love this. So you can look at this. Behavior changes are externally motivated. That is, like, we can encourage people and make them do stuff. No, behavior changes are internally motivated. This philosophy is so important to know for the exam. And so what we can do to engage with the empowerment model is to help the person define the problem, what's bothering you most about your diabetes right now, what's most difficult, unsatisfying, how does it make you feel when you're in that situation? How would the situation have to change for you to feel better? What barriers will you face? How important is it for you to address this issue? What are the costs and benefits? Look at, they're bringing adult learning theory in here. But these are really great open-ended questions that you can use in your practice. What part, like if I have a very limited time to meet with somebody, what's driving you crazy right now about your diabetes? What are you struggling with most? How are you feeling about your diabetes? I'm just going to really get to the heart of what's happening. And then we want to identify short-term behavior change, and they're going to do an experiment. They're going to try something. What are some steps that you could take to bring you closer to where you want to be? Is there one thing that you will do when you leave this office, clinic, hospital to improve things for yourself? And they come back, what did you learn? What would you do differently? What will you do when you leave here today? Just all these different questions are so helpful because we know that motivation comes from the inside, and it really kind of looks at internal versus external locus of control. You'll hear this locus of control. Where do people think the control comes from? Now, if a person has internal locus of control, it means they're in charge, they make the choices, they control their destiny, they make things happen. If there's somebody who feels like external factors are in control of their life, they might say, why does this happen to me? Why do people always treat me badly? Or why do bad things always happen? They think others are in charge of their destiny and their circumstances. One is not better than the other. It's just different ways people interact with their environment and their life. So you'll notice that people might have a little bit of both of these, right? People usually aren't just one or the other, where sometimes they feel like, yes, I'm in charge of this, but then they feel like some things are out of their control. So just kind of listening for that and seeing where that person's coming from. Okay, I'm just looking at the time. Poll question 8. A person says, I am ready to start eating 3 vegetables a day. Using the trans-theoretical model, what stage of change are they in? Are they in pre-contemplation, contemplation, preparation, action, or maintenance? Okay, trans-theoretical model. Let's just get comfortable with this model. I have I think 3 or 4 questions on it. That person says, I'm ready to start eating 3 vegetables a day. Using the trans-theoretical model, what stage of change are they in? Pre-contemplation, contemplation, preparation, action, maintenance. Okay, we'll wait a few more seconds. I'm closing the poll. Great job, team. So 13% of you said B, most of you said C, some of you chose D. Okay, so I am ready to start eating. Doesn't say I am eating vegetables. No, I am ready. It doesn't say I am thinking. So if I said I am thinking about starting, that's contemplation. I am eating is action. This is preparation. I am ready to start eating 3 vegetables on the day. They are on the cusp of moving forward on their behavior change plan. So, okay, let me just go over this again. Contemplation was I am thinking about. Action is I am eating. Preparation, I am ready. Okay, so let's see. 79% of you chose that. Great job. Let's take a look at the model. So the change theory, stages of change, trans-theoretical models say there's these 6 different stages of change. Let's take a look at them in more detail. So here's pre-contemplation, and this person, let's just say what? Oh, movement. Let's just say movement is a conversation we're having. Do you want to move more? Well, I really don't like moving. This is the phase. Okay, just memorize the phase. It's pre-contemplation. So here it gives us a chance to raise doubt. Oh, you don't like moving. It sounds like it's really hard for you. Have you ever enjoyed any type of movement in the past? Okay, now he's in contemplation. Well, I used to dance. I used to love line dancing. I'd go out every Wednesday night and line dance. Huh. Is that something you would think about doing again? Okay, so now we're trying to get him out of contemplation to preparation. Well, I could possibly, I do have my line dancing boots and outfit I used to wear. Maybe I could start, you know, at least putting those on and kind of getting ready. So that could be preparation. Okay, and then what would action look like to you? Well, my sister wants me to do line dancing again. So action would be I go line dancing with her. Oh, is that something you're considering? Not right now, but I'm going to think about it. Okay, he's still in contemplation. It's all right. And then what if he does, he comes back and he goes, you know what? I went line dancing with my sister. It was so much fun. Do you want to keep doing it? Yeah, I think I want to keep doing it. And then they come back again and they go, you know what? I was dancing and it was going great for 6 months. And then I don't know, my car broke down and I just didn't go anymore. And then they're stuck, relapse, right? And so these are the different stages. So there's nope, maybe, okay, I want to, I'm doing it, and we have to start over again. This is just human behavior, you all. You know how we are. It's hard for us to change, to take on new behaviors. We'll do it for a while, then something happens, like it gets rainy, the car breaks down, and then we quit. So we want to really support people through these different stages of change. And then if they get stuck, see if they want to try something different, or maybe they want to get back to what they were doing. Okay. BT was started on a GLP-1 and is losing weight. BT has read articles about the importance of strength training to maintain muscle. They ask you questions about whether using weights or resistance bands is better. According to trans-theoretical model, what stage of change is BT in? Is she in contemplation, acceptance, pre-contemplation, or action? Let me launch this poll. We're almost done. You guys are doing so great. So they're losing weight. They read articles about strength training. They ask you whether using weights or resistant bands is better. According to trans-theoretical model, what stage of change are they in? Pre-contemplation, contemplation, acceptance, or action? I'll wait a few more seconds. Okay, I'm closing the poll. There's a lot of action going on there, but I want to respect your time. So 73% of you said contemplation, 12% said pre-contemplation, 9% said action. Okay, so contemplation is she's thinking about it. That's what it means in English. Is she thinking about increasing muscle mass? Yeah. And she wants to know, are weights or resistance bands better? So this is contemplation state. Some of you chose acceptance. Well, it's not really an acceptance. Let's just look back over here. It doesn't really, it's not part of the trans-theoretical model. Pre-contemplation would just be like, oh, BT's read articles about the importance of strength training. That would be pre-contemplation, not even thinking about it. But since they want to know bands or weights is better, they're contemplating it. Action would mean they're actually doing it. So that would be, oh, they heard about strength training and they bought bands and they're, using bands to increase their muscle mass. That would be action. So here they're just thinking about it. So I wrote out all the different stages here so you all can just review that and get it under your skin and into your DNA, the different stages of the trans-theoretical model. But maybe having those images in your mind. Oh, there's one more. A 49-year-old started bike riding as part of their goal to lose 14 pounds. Using a trans-theoretical model, what best describes their state of change? A, action, B, contemplation, C, termination, or D, pre-contemplation? Let me launch this poll. All right, I see the votes coming in. I think this trans-theoretical model is wiggling into your DNA. Okay, I'm closing the poll because we have 100% of you said A, action. Yes, this person is bike riding, so they've moved past pre-contemplation, contemplation, they're in the action phase. So we're going to kind of keep listening for bike riding, checking in, because we know chances are they're going to burn out. And so then when they stop bike riding, we want to check in what would be another form of activity that you think would be a good match for you. Okay, great job, team. The thing about it is how to succeed with person-centered coaching. I have a whole handout that goes over different communication strategies that might be helpful for you. So a person with diabetes, they are going to have some big emotions in response to being diagnosed with this condition that doesn't go away. And so we want to be present with those emotions, recognize distress. We want to engage in motivational interviewing where it's a non-judgmental intervention, and we want to pull upon their desires and their motivation to move forward. So some strategies to utilize motivational person-centered coaching: express empathy, open-ended questions, and then we're going to recognize discrepancy between their current behavior and their goals. So where they are now and where they want to be. So we're acknowledging that. Roll with resistance instead of pushing back and saying, well, exercise is really important. Oh, it sounds like it's really a struggle for you to move forward with your movement or your exercise goals. Can you tell me more about that? We want to support self-advocacy. We believe in their ability to change, help them develop a plan that's realistic for them. Of course, avoid arguing and confrontation. This is all from the Revive 5 program. I hope you can attend it. It's coming up in June, where Dr. Larry Fisher and Dr. Susan Guzman talk about how the conversation we have with individuals is a therapeutic intervention in itself. When we ask open-ended questions, we listen actively, we engage the person and help them discover their own wisdom, their motivation, and what they want to work on. Just that conversation, it makes a meaningful impact on individuals living with diabetes. So yeah, and I have this whole cheat sheet on kind of summarizing it. So we want to mindfully listen to the person's problems and fears. For this person, they're a truck driver. They're not eating as many vegetables as they would like. And what we say to them is, it's hard to eat vegetables because you are a long haul truck driver. Did I get that right? So we're going to reflect. And he's like, yeah. And then we'll say, well, as a truck driver, I'm curious to learn more about your food choices when driving. Okay, again, we're curious. So, well, I stop at the store, or I stop at, fast food, and I'm grabbing these things. But then he does share with us, I could buy a veggie tray before heading out on my truck. And we want to go, oh my gosh, such a great idea. Yeah, do it. Awesome. But instead of doing all of that, we can do that little happy dance inside of ourselves. We'll go, so just to be clear, you think that getting a veggie tray before you head out would be helpful for you. Did I get that right? Yeah. And then he's going to provide more information on that. So we want to see, it's all about helping them discover what's going to work for them. Which of the following is a SMART goal? Last one. I will buy a veggie tray every day. I will eat more vegetables. I will monitor my blood sugar on a regular basis. I will buy a veggie tray at least twice a week for 1 month. SMART goal is another thing that's going to show up on an exam. Which of the following is a SMART goal? I'll buy a veggie tray every day. I'll eat more vegetables. I'll monitor my blood sugar on a regular basis. I will buy a veggie tray at least twice a week for a month. There's an extra on right there, I just noticed. All right, we'll take a few more seconds. Okay, I'm closing the poll, sharing your result. So 95% of you chose the best answer. Yay, great job. So why is this the best answer? Because it adopts to the SMART goal. So SMART means specific, measurable, attainable, relevant, and time bound. So this, like, I will buy a veggie tray every day. Okay, well, how long are you going to do that for? And is it realistic to, do it every day? It could be, but we need to have a time limit on it. And this one says, I'll buy it at least twice a week for a month. So that's why that's a SMART goal. And it's realistic because it's only twice a week instead of every day would be a perfect score. And so we want to make sure it's attainable and relevant to that person's life experience. We want to avoid the pressure to fix, or we want to avoid trying to control the situation. Really, that person's driving the bus. We're just supporting them on that ride. Let's stop shooting on people, using that should word. You should eat vegetables. You should, check your blood sugar. You should take your medication, and ditch the scare tactics too. We want to lean into a person-centered approach that energizes individuals to take the lead in managing their condition, and step with the providers and supporters. We want to celebrate and recognize each person's effort, even if it's a little tiniest baby step. Just, y'all, if I can't find something that they're doing, I'll just say, I so appreciate you showing up today. Let's make sure we show them we believe in them, because our belief in people makes a big difference. Keep in touch. We have a bunch of different social media places where we share information. We have our question of the week on our blog, and also our CDCS coach app. Please reach out to us if you have any questions, and if there's a way we can support you on this journey, whether you're working for certification, or you just have questions about diabetes education in general. Thank you so much. I'll hang out after class to answer your questions. But for now, this is Beverly Thomassian signing off.